I'm trying to make the remaining lectures in this chapter pretty short, a little encapsulated part about one particular type of respiratory disorder. So, first, we're going to talk about restrictive respiratory disorders. And if you recall in the earlier lectures, I said that a restrictive disorder makes it difficult to um, breathe in for some reason. We'll talk about lots of different reasons. So, by the end of this lecture, you should be able to identify and differentiate between um, several or seven major respiratory pathologies, recognize key symptoms of each condition, and understand how these conditions impact patient function and our role in treatment. So we're going to talk, the ones we're going to talk about in this section are pneumothorax, which is an air accumulation between the lung and the chest wall, which can cause a collapsed lung. It doesn't always, but it can. Atelectasis is where the pleural alveoli collapse, preventing gas exchange. That's never good. Pleural effusion, where you have fluid accumulation in the pleural space. And so when you have extra fluid, the lungs can't expand. It's hard to inhale. Pulmonary embolism is where you have a blood clot blocking the pulmonary artery. That's never good. And even though they're not restrictive in this section, we are also going to talk about acid-base imbalances. So respiratory acidosis is where your blood pH is below 7.35 due to CO2 retention. And respiratory alkalosis is where your blood pH is above 7.45 due to CO2 loss. And we'll talk about why those happen. So respiratory alkalosis is more common with restrictive pathologies, and acidosis is more common with obstructive pathologies, but we'll talk a little bit more about that. So the pneumothorax, also known as a collapsed lung, it allows the lung to decrease in volume. So usually there are different sorts. There's primary, which it just all of a sudden your lung decides to collapse. And they call it a spontaneous pneumothorax. It just happens. There's no trauma or underlying pathology. They don't know why it happens. It's idiopathic. It can be secondary to an existing lung disease, or it could be traumatic as a result of an injury or a medical procedure. So your lung gets punctured somehow, or your rib cage gets punctured, your pleural cavity gets punctured somehow. So the air accumulates between the lung and the chest wall, and it presses inward because the lung tissue is pretty spongy, so it's easy to squish up. So whatever the cause, whether it's spontaneous or there's trauma or it's a medical condition, the signs and symptoms include sharp one-sided chest pain and shortness of breath. It's a medical emergency. If untreated, a large pneumothorax can lead to respiratory distress or death. That's never good. The one-way movement of the air prevents lung expansion. It requires immediate medical attention. In small spontaneous pneumothoraxes, they might heal naturally, but larger ones often require removal of air via syringe or chest tube. So when the air gets in between the lungs and the pleural cavity, you just can't expand the lung. So that's not good. So atelectasis, like a pneumothorax, is sometimes referred to as a collapsed lung, but it's a collapsed lung on a much smaller level. It's the actual alveoli that are collapsed, so it's quite different pathology involved in the whole thing. So alveolar collapse presents gas exchange through the alveoli that are collapsed. So we need that little single cell alveoli, which is surrounded by capillaries, in order to be able to exchange oxygen. So if air can't get in, that's a problem. So if there's a blockage in the bronchiole from a mucus plug or any other kind of material inside the bronchiole, or pressure from outside the bronchiole, maybe from a tumor or fluid, sometimes if infants are born prematurely, they lack the surfactant inside their alveoli that make them stay open. The surfactant um, is produced by the inside of the alveoli, and so a lot of times, if somebody has placenta previa or something like that, and they know that the baby is going to be born prematurely, they will give the mother medication ahead of time to help develop the surfactant lining of the lungs so the premature infant can actually breathe, which is lovely. Um, So poor production or poor distribution of surfactant can also lead to atelectasis in adults. And smoking and underlying pulmonary disease are significant risk factors, and sometimes post-surgical complications. And post-surgical complications are the most common cause of atelectasis. So what we're going to be doing in PT, and this person's in the hospital. I'm just telling you that right now. We're going to be doing deep breathing exercises. We're going to be encouraging them to use their incentive spirometer and their flutter valve usually. We're going to be doing ambulation activities with deep breathing. We're going to be teaching coughing techniques. We might be doing percussion and postural drainage, although in the hospital that is often done by respiratory therapists. Maybe if you work in a small 8-bed hospital in small town USA, you might be doing that. But in most larger hospitals, they have respiratory therapists that are going to be doing that. But we, in physical therapy, we are supporting the respiratory therapists. And I have learned a ton of good things from respiratory therapists and speech therapists working in the hospital. So, but whatever we can do to help the physician be patient, the position of the patient, postural drainage, coughing techniques, anything we can do to get them moving is a good thing. And that's when someone has a chest tube in, you're glad you have a walker to hang that chest tube on. It's handy. So pleural effusion is when fluid accumulates in the pleural space. And so it decreases lung expansion capability. So it can be caused by tons of things: heart failure, kidney failure, liver failure, liver cirrhosis. So when the normal airspace of the lung is compromised by fluid accumulation, there's less space for the lung to expand. And so then you can't move as much air in and out of the body. Never good. So it can cause shortness of breath, coughing, and fatigue for the patient. They're fatigued because their cells are not getting enough oxygen. So chest expansion can be diminished over the area of effusion, and that's where you're going to hear the pleural rub. It's that grating or squeaking sound when you auscultate. So the fluid's usually expressed through a needle biopsy, or they suck it out through a needle biopsy. And they might put in a chest tube to drain. And if they do a culture and sensitivity on that fluid and it is infected, then they might be using antimicrobial drugs. So the signs and symptoms that you're going to see from the patient: shortness of breath, coughing, fatigue, diminished chest expansion, and pleural rub that you're going to hear, and abnormal breath sounds. Stuff just isn't going to sound right. So with a pulmonary embolisms are interesting, and so with pleural effusion and atelectasis, you're going to see those in the hospital. Pulmonary embolism, you might have somebody coming into your outpatient clinic post-surgically, and they have a DVT, usually, that travels through the heart and lodges in the pulmonary artery, causing tissue ischemia and death. So they might have sort of vague symptoms at first. I had one patient come in after an orthopedic surgery, and the only symptom he had is his wife said, "There's something not right with him." That was the symptom. And we sent him back to the doctor's office. The doctor sent him to the ER, and they did imaging, and he had a pulmonary embolism. So and they're bad. They can kill you, and they can happen spontaneously. So when you block the pulmonary circulation, it causes damage to lung tissue because it occludes blood flow to the area supplied by that vessel, and it can produce ischemia, which is deprivation of oxygen in the tissues, and tissue death. So that's never good. The dead tissue can't perform gas exchange, and so less oxygen is available for circulation. So it's just it's a bad cycle, let me tell you. So besides DVT, other risk factors include recent immobilization or surgery, and that's kind of where I've seen pulmonary embolisms a lot. Um, Obesity or pregnancy, inherited blood conditions like blood clotting conditions, heart disease, smoking, it's always smoking. Everything, smoking's bad. Let's just say it. Smoking's bad. If estrogen replacement therapy can sometimes cause pulmonary embolisms and heart disease, of course. So the signs and symptoms: dyspnea, chest pain, coughing, and hypoxia. Um, you can also have hemoptysis, which is coughing up blood, cyanosis, which you're turning blue, syncope, you're fainting, and you can have a weak, rapid pulse. So it can mimic a heart attack, chest pain, dyspnea, all that stuff. So, but whether it's a heart attack or pulmonary embolism, let the people at the emergency room decide. That is a medical emergency and it requires immediate medical attention. So when we start, so that's basically our little our restrictive things. And we're talking about respiratory acid-base disorders. So our normal blood pH should be between 7.35 and 7.45. And that is the pH at which our cellular metabolism needs to function. The chemical reactions that make up our cellular metabolism function best at that pH. And so if we get out of range, it can lead to death on either side, acidosis or alkalosis. So respiratory acidosis is where your pH is less than 7.35. You have an excess of hydrogen ions, you have an excess of CO2. It's often caused by hypoventilation, or if the patient's breathing is too slow or shallow, or the breathing suppressed because of disease or drugs. The lungs are unable to remove adequate amounts of CO2, and CO2 builds up in the blood, and that's hypercapnia, if you remember that. Excessive CO2 causes bicarbonate ion levels to decrease, and the kidneys try to compensate by releasing extra bicarbonate into the blood. So I have a supplemental lecture talking about all the little gory details about this if you're interested, if you're just really into the chemistry of it. And of course, I am. But just know that if the type of questions that show up on board exams and whatnot, they say, you've got this patient, here's their blood pH, here's their symptoms, and are they in respiratory acidosis or respiratory alkalosis? Well, if their pH is below 7.35 and their CO2 is high, then you're in respiratory acidosis. So respiratory acidosis can be an acute or a chronic condition. A lot of people with chronic obstructive lung disease live in a state of respiratory acidosis. So they're slightly acidic. They're not to the really bad end of it. But acute respiratory acidosis is considered a medical emergency that's associated with head trauma, cerebral disease, neuromuscular disease, drug overdose, or airway obstruction, or an acute asthma attack. So chronic respiratory acidosis is a secondary condition to COPD, some neurological diseases, some interstitial lung disease, pneumonia sometimes, obesity, because people, they're just not functioning at optimum, and severe scoliosis, because again, their respiratory system is not functioning at optimum. So lots of things can cause it. Treatment of respiratory acidosis is directed at treating the underlying condition. So if you don't fix the underlying condition, it's still going to go. So the other side of it is respiratory alkalosis. So if the pH of the blood is greater than 7.5, you are in respiratory alkalosis. So hyperventilation is the most common cause of respiratory alkalosis because you're losing excessive CO2. And so that can be secondary to a lot of conditions. Oddly enough, also COPD, asthma, and pulmonary embolism can cause respiratory alkalosis. So COPD can cause either, and asthma can cause either. It just depends on what's going on in reaction to the primary condition. Hyperthyroidism can cause hyperventilation because it increases your metabolism. And sepsis Sepsis is never good. It can kill you. It's one of the top 10 things that can kill you. Can also be a response to living at high altitude, or as a central nervous system response to fever, anxiety, pain, or trauma. So, lots of different things can cause hyperventilation, which can then cause respiratory alkalosis. So, for both respiratory alkalosis and acidosis, it requires treatment of the primary source. What's causing it? Treat that. So our kidneys are involved in everything. They're involved in creating new red blood cells. They're involved in regulating acid-base balance. Your kidneys are the slowest acting but longest lasting way to change your acid-base balance. Your lungs are the fastest or fast acting but not as long lasting ways to share your acid-base balance and get it in order. If your acid-base balance is out of order, that can kill you. Bronchiectasis is a condition where the airways of the lungs are permanently widened. Usually it's due to chronic inflammation leading to excessive mucus production and frequent infections. So lots of different conditions are associated with bronchiectasis, including pneumonia, tuberculosis, lung cancer, immunosuppressive disorders, interestingly enough, and cystic fibrosis, which is a genetic disorder. The breakdown of the airway walls is caused by continual excessive inflammatory responses in the lungs. So you get this inflammatory response, the walls get beat up basically, and they eventually break down. So the expansion of the airways also causes excessive mucus production. And the mucus, unfortunately, is a great place for infections to take place or infections to get a toehold. So especially for bacteria. And so people with bronchiectasis tend to have frequent lung infections and can cough up copious amounts of purulent sputum. Nice, right? So the bronchiectasis can be characterized as obstructive, um, but since it's associated with other lung and systemic conditions, it's kind of categorized as a general condition. So it can be restrictive or obstructive. So your signs and symptoms are going to include a productive cough with purulent sputum, shortness of breath, hemoptysis, coughing up blood, fever and chills during exacerbations, and finger clubbing. So that's never a good thing. None of those things are good, are they? So when one of the techniques that we will learn next fall in our special topics class is pulmonary physical therapy techniques. So we're going to learn percussion and postural drainage, which where you mechanically loosen the secretions, breathing exercises, and postural correction. The a lot of times, like I said, unless you live in small town USA where their respiratory therapists are thin on the ground, usually respiratory therapists are going to be doing percussion and postural drainage, but it is part of our body of knowledge that we learn that. Other interventions that we might be doing for bronchiectasis are mucus thinning devices. There's a thing that's called a flutter device. So there's the incentive spirometer, which encourages you to inhale more. The flutter device is an expiratory pressure device. So you blow into it against pressure and it strengthens your exhalation. The flutter devices, a lot of them are green and they're like the size of a harmonica. They're not a harmonica, but a lot of the respiratory therapists that I worked with at the hospital call them the pickle. So imagine a green pickle that you blow into. Of course, patient education on smoking cessation. You want to get vaccinations because you do not want to get infections and make your bronchiectasis worse. So when the disease progresses, it's characterized by exacerbations, often requiring hospitalization and remissions. So, like a lot of things, as they get worse, you have more symptoms. So Our role in respiratory care, assessment and monitoring, as we are in a lot of things, vital sign monitoring, oxygen saturation, breathing patterns, and activity tolerance, patient education on energy conservation, their home exercise programs, risk factor modification, and we'll talk about specifically which exercises go with which diseases when in our pulmonary therapy lab. And then recognizing an emergency when what are our red flags? The therapeutic interventions we're going to be doing are breathing exercises, airway clearance, positioning, and progressive mobility. So medical emergencies that we need to recognize: tension pneumothorax, which is one-way air movement, and lung expansion. So basically it's a collapsed lung. Lung expansion is impossible. Pulmonary embolism can mimic a heart attack, or it could have very vague symptoms, but it requires immediate attention. Acute respiratory acidosis can be associated with trauma, drugs, or airway obstruction. So PT interventions can make a difference of preventing atelectasis through mobility and breathing exercises. Post-surgically, this is very, very important. Secretion clearance in bronchiectasis, and patient education about activity modification and energy conservation. So always work within the scope of your practice and communicate your findings to the medical team and the supervising PT. But we can do a lot to help these people.